will report on classification in natural history.
Mr. Chairman, ladies and gentlemen, it's my great honor to present our contribution about the introduction to the spondylolisthesis with classification in natural history. We can define the spondylolisthesis like anterior or posterior displacement of the vertebra. Its origin from these two Greek terms. And when we are looking to the history, it starts with Belgian obstetrician Dr. Herbinot in 1782. He reported a bony prominence anterior to the sacrum that obstructed the vagina of a small number of patients. And the modern, in 1889, the spondylolysis and its relationship to degenerative joint diseases in the prehistoric southern United States. That's mean that most oldest bone samples with spondylolysis was found in Alabama. It is from 6,000 years BC. And in this population, there were 17% of spondylolysis. In comparison with today, it's 6% about. The main problem in spondylolysis is in the isthmus, in lamina, and in the lower articular process. And this complex and this damage of this complex leads to the flexion ventral translation instability, which produces the spondylolisthesis as it is. We can divide between the spondylolysis, this means interruption of pars interarticularis, spondylolisthesis, which means pathological slipped vertebral body, and spondyloptosis with shift of the whole vertebral body. On the X-ray examination, we can measure the slip and a slip angle. Slip can be classified according to Meyerding into the 5 degrees from 0 to spondyloptosis, and it's a very useful classification for many years before. And nowadays the history started with Neugebauer in 1888. Neugebauer divided spondylolisthesis into the congenital defect of isthmus, fracture of facet, and fracture in pars interarticularis. And the modern, historic modern classification starts with Newman in 1955 and 63, and he divides spondylolisthesis in 5 types. The most modern in this time classification is starting with Wilson, Newman, and McNabb from 1976. They divided spondylolisthesis into the 6 main types from dysplastic, type 1, type 2 isthmic, type 3 degenerative, type 4 traumatic, type 5 pathological, and type 6 iatrogenic spondylolisthesis. Type 1 dysplastic occurs mostly at the level L5S1 and mostly is associated with congenital dysplasia of upper sacrum. And type 2 isthmic can be divided into the 3 types: type A lytic type, type B elongated type, and type C acute or trauma type. The next step in classification of spondylolisthesis was done by Marchetti and Bartolozzi in 1997. They divided the spondylolisthesis in 2 types into the developmental, which means the high dysplastic or low dysplastic, and acquired, which means traumatic, post-surgery, pathological, and degenerative. This classification can be divided in these 2 main types, high and low dysplastic in development type, and it can be also with lysis or with elongation. The second type acquired can be done by traumatic, means the acute or stress fracture, by post-surgery, can be done by direct and indirect surgery, by pathological way, means the local pathology or systemic pathology, and finally with degenerative, it can be primary or secondary. From 2006, we have new classification done by Mac, Tiong, and Lebel. They divided, or they measured three main parameters, means sleep grade, degree of dysplasia, and sagittal sacropelvic balance. Sagittal sacropelvic balance is the new for these classifications. That means sleep grade, we can divide it into the low or high grade. Degree of dysplasia means the low or high dysplastic spondylolisthesis. This is the table of 8 main types of this McTeoch-Lebel classification, and their groups and subgroups are organized in an ascending order of severity, and it can be like guide for evaluation and treatment of the mostly lumbosacral spondylolisthesis. You can see on the table that the most low type starts with low grade, low pelvic incidence, and the most important grades is with high grade and with high pelvic incidence. Spinal deformity study group from 2008 by the same authors divided in this the spondylolisthesis in this table. That's mean again 5 main types from low grade and normal pelvic incidence with normal spinal pelvic balance to the most important grade type 5 ambulance and ambulance spinal pelvic balance. And the last step to the classification of spondylolisthesis is from this year. They measured the same group, spinal deformity study group, measured 3 main parameters and 6 main types they established. Means from one type of type 1, a low-grade spondylolisthesis with low pelvic incidence, normal pelvic incidence, or high pelvic incidence. And the second one, the important type, is high-grade spondylolisthesis with balanced sacropelvis, retroverted sacropelvis with balanced spine, and type 6, retroverted sacropelvis and unbalanced spine. In conclusion, we have to mind that we have to in our mind the simplification. That means we have to speak and think about dysplastic type, which means that this is formed burst defect. About the isthmic type, which means the stress fracture in the connective zone between vertebra. The third type, the most important type, also is degenerative, which means the arthritis in the facet joints, traumatic fracture due to the trauma, and secondary disease that changes the mechanical strength of the bone. And very shortly about natural history of spondylolisthesis. We have to divide this spondylolisthesis into the grades, low or high grade. When we are speaking about low grade, most patients with low grade spondylolisthesis are asymptomatic, and sleep progression is up to 4% in childhood, but also the pars defect usually occurs before the skeletal maturity. Typically symptoms appears only in adulthood. Mild to medium back pain due to degeneration in adults. The indication for conservative treatment is mostly useful for this low-grade spondylolisthesis. We are indicated these patients with small problems, low sleep, and no neurological symptoms, and we can recommend the bed rest, orthosis, rehabilitation, and some drugs to relieve the pain. When we are speaking about high-grade spondylolisthesis, means the between 5 or to 10% of all spondylolisthesis. They typically develop during childhood or adolescence, and mostly they are associated with a high risk of progression. And symptomatic high-grade spondylolisthesis is more likely to cause pain. There are 2 typical problems in childhood, or the problems with progression. In childhood, the progression is related to the skeletal immaturity and the highest risk of progression of sleep. And in adults, the progression is related to the disc degeneration, and most appears during the 4th and 5th decades. When we are looking to the most white paper from Beutler and Fredrickson from 2003, this is the very long-term 45-year follow-up study with 500 children with first grade of spondylolisthesis. It was prospective study with X-ray examination, AP lateral, oblique, standing, and prone, and from 1999 also with MRI. And also they did the back pain questionnaire till 1988 and then SF36. And the measured person sleep, person lumbar index, sleep angle, disc height, and the level of sleep and above, and sacral inclination. And in this study, 30 children, they found 30 children with defect of pars interarticularis. No subject with an unilateral pars defect had developed slippage at follow-up, and progression of slippage was associated with disc degeneration. Progression of sleep appears to be slow. There are some theories for back pain in spondylolisthesis. Mostly there are two theories. One is that the main problem is the segmental instability with excessive forward translation during flexion, and the second one that the problems are coming from excessive tension on the annulus of the inferior disc and foraminal stenosis and the level of the slip. This is the picture of natural history of adult spondylolisthesis. When the disc loses its structural and functional integrity, the lumbosacral junctions becomes unstable, and the slip progresses with finally back and leg pain or neurogenic claudication. But we have to mind that the magnitude of symptoms is not necessarily related to the grade of slippage, and some symptoms may be related to the nerve compression, which can happen with any grade. And this is also very visibly seen in this study of Kalichman, where the 3,529 participants was examined with multi-detector CT imaging, only 188 with low back pain and 21 patients with spondylolysis, and did not reveal a significant association between the observation of spondylolysis on CT and the occurrence of low back pain. Indication for surgical treatment is heavy sleep, progression in sleep, main pain, and neurological symptoms. And in conclusion, to exactly classify various types, is necessary to identify affected vertebral structures, its origin and character. The intra and inter-observer reliability is very important for mutual communication. The natural history is related to the age and type of spondylolisthesis. The magnitude of symptoms is not necessarily related to the grade of slippage, and various treatment methods are using for the correct treatment of spondylolisthesis. Thank you for your attention.
Thank you.